Fine.
Nice to see everyone, sir. Honored to be here. First off.
Aditya, I worked with your grandfather also.
Oh, thank you. No, thankfully, his goodwill and legacy is helping us by God's grace.
Yeah.
Lot of work done.
Nene madam, good morning. Nene madam at this age also is very regular in attending our meetings. Not only that, he suggests very good speakers also. That's very helpful actually, getting the right speakers. So we are live on the YouTube now and we can start the meeting. So good morning all. Welcome back to Saturday Club of Baroda meeting. And today we have very interesting topic, endophthalmitis, systemic considerations. So we'll be knowing, we'll come to know more about it from Dr. Aditya Sudhalkar, who is a consultant ophthalmologist in Vadodara. He did his MS ophthalmology and he has a very special interest in disease of retina and vitreous and endophthalmitis. He did his fellowship in vitreoretinal disease and surgery at LV Prasad, very reputed institute, LV Prasad Eye Institute, Hyderabad. And he has prolific research publications. Although he is in private practice, he has 67 publications in national and international journals. And is also co-author for book on minimal surgery for retinal detachment. And he is faculty and CRISIC travel grant from EURetina. I am not very sure about what EURetina is. Aditya,
it's a European Retinal Society organization, sir.
Okay. So you are a faculty there also.
Yes.
And very interesting and something which we do not know much about Aditya is that he's an avid student of astrology. And I had a choice actually to whether to have a talk on ophthalmology or astrology. Then I preferred being a scientist.
You prefer the conventional.
And then sometime later when all my colleagues agree that we can have this topic here, we'll have astrology also from Dr. Aditya. So Aditya, thank you very much for joining us. And it's over to you now. And you have about 45 minutes to talk and we'll keep 10 minutes for discussion. So over to you.
Thank you, sir. It's always an honor to be here. This is the third time that I'm presenting in this Saturday Club meeting, and it's always it's a great learning experience. So just confirming my screen is visible and
yes.
I'm audible.
Yes.
So, endophthalmitis is a very scary topic for everyone, not only for, for ophthalmologists, but for everyone in general, because it denotes inflammation and infection in a closed space and something that is not, many parts of the eye are not readily amenable to, transport with blood. So a lot of eye areas are what we call privileged areas, such as the cornea and the lens. And these structures have essentially never developed a vascular supply. And that is in part to keep their transparency intact. Now, whereas the primary role is, of course, very functional, the problem is that whenever there is an infection in the eye, these structures are the ones that are most affected, including the vitreous, which is a gel-like body in the center of the eye between the lens and the retina. So essentially, the whatever the body's defense mechanisms are, inflammatory cytokines, white blood cells, they do not have ready access to many tissues within the eye. And hence, for a very long time, endophthalmitis actually entailed just removal of the eye, let alone cure removal of the eye. Or at the most, you would end up with a hysical eye. That is a shrunken, non-functional globe. That's all. So, there are several studies. It is an ongoing topic and it is continuously being published. For the sake of completion, this is the definition, that is intraocular infection affecting the inner courts of the eye associated with significant progressive vitreous inflammation. And this is what is termed as endophthalmitis. It is an ophthalmic emergency. And it is one of those few conditions in ophthalmology which can be termed an emergency. So the others, of course, are central retinal artery occlusion and to some extent macula involving retinal detachment. So these are the three most important emergencies. There are other urgent situations such as an acute attack of angle closure glaucoma and so on and so forth. But this by far is the most dangerous. God's grace and with the advent of superior technology and superior antibiotics and techniques, the vast majority of eyes, and I may go on to say that nearly 99% of eyes can be saved, and most of them, of those 99%, maybe 95% can be saved with significant vision. So specifically what I chose for today, keeping in mind the diverse, crowd of physicians and surgeons and general, medicine men, all sorts of medicine men, I thought is endogenous endophthalmitis. However, there are systemic considerations for even post-operative endophthalmitis. So if we are to divide endophthalmitis into three different groups, or, look at the three main causes, the first and foremost is, of course, post-operative endophthalmitis. Whenever the patient has undergone any surgery, let us say a cataract surgery or retinal detachment or glaucoma surgery, and then, there is ingress of microorganisms in the eye and they lead to inflammation. The second, of course, is traumatic. Any traumatic injury, say with a copper wire or glass, something that is penetrating, which has actually, stab wound in the eye. And that leads to direct inoculation of the ocular structures with organisms. The third is endogenous endophthalmitis, where there has been no intervention or no trauma to the eye per se, but there are systemic factors which lower one's immunity and make the eye susceptible to attack by organisms circulating within your body. So generally, this is associated with either urinary tract infections, or in cases of septicemia, or in patients with immunodeficiency syndrome, such as PLHA patients and so on and so forth. Of course, the most recent condition in which this was seen was corona, and all the systemic conditions that were, the systemic therapies that were given, that led to not only endophthalmitis but also a very frightening epidemic of mucormycosis. And the kind of cocktail that was initially administered to patients, and we have a publication on why mucormycosis was so prevalent, and we did a regression analysis. And what we saw is that it was not just the use of systemic steroids, it was systemic steroids combined with antifungals, antiparasitics, and antibacterials, which the patients were put on. And that, of course, it was with all these antifungals and antibacterials, you clear the field for the fungus, and then you lower the immunity with steroids, and that is how it managed to take hold. But anyway, that is a separate topic, and I won't spend much time on it. So this is something interesting, and we actually published this, and this is endogenous endophthalmitis in the setting of COVID-19 infection. We have a multinational group of co-authors, but all the cases were from India. And what I'm going to do is just put 3 or 4 case illustrations and discuss all the management strategies and whatever findings we had along with them. So this was a 74-year-old gentleman who had just recovered from COVID-19 pneumonia and who had pain, redness, and watering, along with decreased vision since a fortnight. He was diagnosed elsewhere to have post-COVID ocular inflammation, and he had been put on topical steroid and antibiotic therapy, along with a cycloplegic, namely atropine. So he had been on this for 2 weeks. His vision was progressively reducing, but there was no attempt at surgical intervention, although surprisingly, he had been seen by a couple of retinal surgeons. Now, during COVID, he had been on ventilator support. He had received remdesivir, steroids, and tocilizumab. He was non-diabetic, but had had prolonged steroid administration. Now, this is what he presented to it, and this is just a composite. In the interest of time, what I've done is I've put all the relevant photos in one big picture. So to the top left is the ultrasound scan of the eye, and what it shows us is many hyperechoic membranes. So, which is probably the first sign of suggestion of endophthalmitis. This 1B is the picture which shows you a fundus photograph. Essentially, you can't see anything because there is so much inflammation, but that is what it is. 1C is a slit lamp biomicroscopic photograph of the anterior segment of the eye, that is from the cornea to the lens. And maybe it's not so, but if I can zoom in, and you can see this yellow streak here at the bottom of the cornea, and that is hypopyon. So all of this is suggestive of evident endogenous inflammation. Now, eventually what we saw after the first vitrectomy is that the patient had a hole in the retina, and that is marked out by the blue arrow in 1D. The patient initially had an excellent outcome. You can see the entire fundus. There is absolutely no sign of inflammation. And of course, something interesting that came out is that during pars plana vitrectomy, which is the standard of care for endophthalmitis management, we also sent it for PCR, and we reported, and this is published now in the journal, the vitreous positive fluid turned out positive for PCR for coronavirus. Now, this is what he initially, this is a blown up image of what he presented with. The blood culture in this case came out negative. The urine routine microscopy was also negative. There were hardly 2 to 3 pus cells. But the urine culture tested positive for E. coli and K. pneumoniae. And I have written Klebsiella was sensitive to colistin, but that too was iffy. So it wasn't really. So essentially, it was a multi-drug resistant Klebsiella pneumoniae infection. And unfortunately, despite the excellent primary outcome, eventually the patient ended up with a lost eye. Now, in this case, these are just his, parameters during his COVID infection and everything. Interestingly, as you can see, the antibiogram has also been mentioned here, and Klebsiella pneumoniae is resistant to everything. Also, what is interesting is that he had asymptomatic renal stones, which were the source of infection in this case. So, this is his D-dimer and ferritin levels during his corona treatment, of course, and this is just a blown up picture demonstrating how vitreous fluid showed COVID-19 positivity. So not just the swab, but also the vitreous fluid, which we have sent for PCR sampling. The patient had developed a retinal detachment. We operated that. It went off well. However, 3 weeks later, I think the Klebsiella pneumoniae component took over, and he came back with recurrent inflammation. So now you can see that there are multiple hemorrhages. The disc appears pale. The vessels are all constricted. And the view overall has gone down. Eventually, the patient was advised removal of his intraocular lens. So he had undergone cataract surgery about 6 or 7 years ago. We did multiple things. We actually infused colistin in the subretinal space. Nothing came to our rescue, and eventually, in this particular eye, we had a bad outcome. Now, so the point here is, of course, that systemic disease, immunity, and everything is important. Now, IOL explant is also an option in these cases because, like I said, the capsular bag in which the intraocular lens is placed after cataract surgery is avascular. So the organisms have they find a safe haven there. They can remain sequestered, and then they can proliferate whenever, the immunity goes down again. So these are the things. Now, systemic conditions are important even in post-operative cases. And the next, the photograph that I'm going to put up next should demonstrate that. Now, to the left of the screen is a patient. So both these patients were operated on the same day as per their records. And the date specifically was 1st of December, 2023. That is last year, end of last year. Now, to the left is a patient who developed a non-tubercular mycobacterium infection. And that is what he was eventually found to have 40 days after the surgery. So he came back on the 10th or 12th of January with a complaint of pain, decreased vision, and foggy vision. So to the right is a patient who initially did not have much inflammation, but she presented 15 days after the cataract surgery. That is on the 15th of December, 2023. Initially, both patients did very well, but the patient to the left, that is the gentleman who presented 40 days after surgery, continued to do very well. And that is because he was otherwise systemically healthy. On the other hand, the lady whose photograph is to the right, she initially did very well, but then, as I said, the organism remained sequestered in the capsular bag, and eventually just yesterday, we ultimately had to explant the lens. Now, the non-tubercular mycobacterium source was found to be the the flash autoclave machine in one of the trust hospitals in the outskirts of the city. But the point here is that it is the systemic consideration that was important in the different outcomes of both. So both of them had the same organism, both of them operated on the same day, both of them received the same lens. But it was because this lady who needed to undergo an IOL explant was a heavy diabetic. So we had to wait for nearly 3 months for her urinary infection to resolve, for her diabetes to come down. And then, in a very narrow window, we could operate her wherein her sugars were well controlled. Now, the third, another case, again, so this was a lady who was, who had been on treatment for rheumatoid arthritis for time and again, and she had received immunosuppressive therapy, including steroids. And she presented to somewhere else initially with a complaint of decreased vision, mild pain, and the initial picture must have been misleading and probably looked like rheumatoid arthritis associated uveitis. And the retinal surgeon who saw her initially continued to treat her on those lines. And her vision continued to drop. So from 618, by the time she had come to us, she was almost hand motions. So from 618, which is decent vision, not great vision, but decent vision, maybe 60, 70%, she had now come down to hand motions, which is very, what do you call, very scary. So, sorry. Yeah. Anyway, so now in this case, if you see the slit lamp photograph, there is very evident exudative thick membranes on the iris and on the pupillary margin. So this is, this is a very, this is the sine qua non of an endophthalmitis case. And in this case, eventually it turned out to be a fungal endophthalmitis, a consequence of chronic steroid therapy and chronic immunosuppression in a lady who was later found to have a fungal urinary infection. So finding the right signs and correlating it with the systemic condition. So initially it is justified to treat the patient on the lines of uveitis, but if the vision continues to grow down, especially after 3 doses of intravenous methylprednisolone, then you definitely need to re-look at your diagnosis. Now, this is an extremely interesting case. So this was a 42-year-old male who came to us with a complaint of yellowing of the eye, yellow exudates in the eye. So he had a complaint of recent dental extraction about 6 days prior to presentation, pain and profound visual loss in 2 days. Now, during the dental extraction, he had been given amoxicillin clavulanic acid, which is standard prophylaxis, of course, to prevent bacteremia and infections. But what is also interesting is in the left eye, and he had undergone a left tooth, a tooth extraction on the left side. He had also received a subtenon steroid injection for uveitis. So his primary complaint had been uveitis, but because he came from from abroad and he only had about a week or 10 days. So generally what happens is they tend to club all their treatments together systemically without a thought to cross infections or anything. So he had a subtenon steroid injection for uveitis in the left eye. And then he underwent just 3 or 4 days later, dental extraction. This is what he presented with. So you can see that half of the chamber is filled with pus, hypopyon as we call it. And this red dot, this is the hemorrhage. This is the area from where he had the subtenon steroid injection. So this is what he presented to us with. Eventually, he received a vitrectomy. The air bubble that we have put in is filtered air to maintain the anterior chamber. And we were able to clear the pus. So again, one composite, the 2A, that is the figure 2A, shows ultrasound images, hypoechoic shadows suggestive of inflammation in the vitreous cavity. 2B is the slit lamp photograph. It shows a completely dense membrane at the time of surgery, which is totally occluding the pupil. And 2C is the final outcome. We put in silicone oil and we were able to salvage the retina. His vision improved from query light perception to 618. So again, these are blown up images of the same and just a short video. Won't go into too much detail, but this is what it looked like inside. So the standard of care nowadays for endophthalmitis is pars plana vitrectomy. Some prefer to call it bimanual vitrectomy, along with intraocular antibiotic injections. So a whole host of antibiotics can be injected intravitreally, including vancomycin, ceftazidime, linezolid, antifungals, and so much so that even immunosuppressive, like methotrexate can be injected intravitreally, albeit for other causes. So ultimately, we were able to salvage the eye. The patient continued to have recurrent uveitis, but thankfully, the endophthalmitis did not recur. Now, in this case, the organism that we noted was Stenotrophomonas maltophilia, which for a very long time was confused with Pseudomonas aeruginosa. Again, gram-negative. But now with the availability of Vitek 2 since number of years in Baroda, we have been very fortunate to be able to identify even these subspecies. So this non-tubercular Mycobacterium, we were able to subtype it into Mycobacterium brisbaneae and W and so on and so forth. So it's really we are lucky to have this, because a lot of cities even today do not have Vitek 2 for diagnosis. So this is what it was sensitive to. He responded very well, and the final outcome was more than satisfactory. So this is what we had published, and we had published this during my fellowship, but this was just like an add-on case to the same thing. So here, the most important things for consideration during any intervention for endophthalmitis is early presentation, a close follow-up, and a compliant patient. What happens is the patient is scared and he will have multiple consultations. He or she may undergo multiple consultations and eventually end up with no treatment. Rolling stone gathers no moss, and that is what happened. But explaining the management and the possibility of multiple interventions at the start should ensure compliance with therapy in the long term. Now, again, this was another patient, vague complaints of sore throat post-COVID, and was eventually diagnosed with MRSA, endogenous endophthalmitis. So this is what she presented with. Again, wildly fluctuating sugars. They used to fluctuate from 30 to 300, it seems. She was an antihypertensive. She was on antihypertensives, dyslipidemics, and the whole plethora of drugs. Again, thankfully, we had a very good outcome in this case. 3A is the initial presentation, 3B is the fundus photograph at initial presentation, and 3C is the post-operative photograph. Those black scars that we see on the retina is laser photocoagulation that she had undergone for diabetic retinopathy many years ago. And this yellow, meniscus-like line that we see in the center is the silicone oil that we had to inject post surgery. So silicone oil is considered to be a very good bacteriostatic. So in cases where you suspect that the eye has been badly hit by endophthalmitis, there is a membrane on the ciliary body, and that it may lead to phthisis or shrinking of the eye, it is a good idea to put in silicone oil. And the slightest hint of any retinal tear, it is also a very good idea to put in silicone oil to prevent a retinal detachment, which almost invariably would end in blindness. Again, a very interesting case, a 4-month-old baby who caught corona from his mother. Obviously, the mother had to keep the baby by her side. And then this is fungal endophthalmitis in a 4-month-old baby. So this was Candida. And fortunately for the baby and for us, there was a very good outcome. So eventually the baby, is undergoing visual rehabilitation, but she's growing up very well and she's doing very well. So again, systemic disease picked up from somewhere else, leading to endophthalmitis. Now, another interesting organism in this is Pantoia agglomerans. Again, it is Enterobacteriaceae, generally seen in fecal material, but also seen with intravenous fluid and propofol. So even anesthesia, and this may not be so common in India, but in the West, for economic considerations, a lot of cataract patients undergo general anesthesia or cataract surgery in general anesthesia. So these blood products and total parenteral nutrition are also risk factors for Pantoia agglomerans. Trauma and postoperative endophthalmitis is also a possibility, but it is not as common as these systemic administrations. So with Vitek 2 DNA sequencing, with the use of all of these antibiotics, we are relatively lucky. We are fortunate that we are able to salvage a lot of these eyes. So this is another publication that we managed to put out during my fellowship. And again, just a case illustration, a patient, this is what he presented with. This was the ultrasound scan. Now, as you can see in this scan, there are not many echoes, and this is a characteristic of Pantoja agglomerans endophthalmitis. This is what the colonies look like, and this is where I end. But the overwhelming majority of eyes today can be saved. Newer sensitivity patterns have to be recognized. Initially, what used to happen is that vancomycin, ceftazidime were good generic antibiotics to be injected at the end of surgery. Oral antibiotics and steroids still have a role. So steroids definitely have a role, and more so in bacterial endophthalmitis, where inflammation causes equal amount of damage as do the bacteria themselves. Now, for a very long time, there was a study called the endophthalmitis vitrectomy study, which initially reported that intravenous antibiotics are not really important, and that you should operate only if the vision goes down to light perception or less. However, that was with the older vitrectomy machines. Nowadays, we try and encourage the patient to have a complete, surgery at presentation itself. So if the patient presents today, if possible, I would like to take up the patient immediately in the afternoon or evening, or at latest the next morning. The sample has to be collected at the time of the surgical intervention itself. So generally what we do is that we have a vitreous cutter. We attach a 2 ml syringe to it. We take a sample and transport it immediately to the lab. Ideally, the lab, somebody from the lab should be standing in the OT as well, and you should directly inoculate it. The most preferred media that we use are blood agar, chocolate agar, subarrowed agar, and anaerobic medium. Anaerobic is important because initially when we had this NTM epidemic from this trust hospital, it was the anaerobic agar that showed growth after 3 to 4 weeks. Subsequently, in some cases we were able to derive growth even on blood or chocolate agar. But these 4 media will cover most, if not all, organisms. Now, what we do is that pars plana vitrectomy, like I said, is the way to go. If I can just go back to the surgical video, you will see that the surgery is carried out through very small ports. So this is about 0.7 to 0.8 millimeters wide, these yellow micro cannula as we call them, and it is essentially a sutureless surgery, and which is why post-operative recovery is very fast. Now, this is quite common even after cataract surgery. Within, say, 48 hours, we allow the patient a head bath. Even if water enters the eye, it is not a problem. So these are self-sealing sutureless incisions, which has tremendously enhanced our post-operative outcomes and patient comfort. Initially, of course, everything had to be sutured. The patient could not go out of the house and so on and so forth. But now it is no longer a consideration. So overall, because technology and techniques have improved, outcomes have also improved. An important consideration for any endophthalmitis case, be it traumatic, be it endogenous, or be it post-operative, intraocular lens removal, in the event that there is an intraocular lens, is often part of the treatment protocol, because that is exactly where those organisms go and lodge. And there is no way that they can be removed from that area. So, like I said, the most important thing is, of course, all of these, tests, now that they're available, we can do it. But early diagnosis and a biopsy, a vitreous biopsy. Now, what happens in many cases is the patient is unwilling to undergo surgery. And then, we tend to treat these patients on a generic basis. Let us give gram positive and gram negative coverage both, intravenous, then just give an intravitreal injection. And then, because the patient is often not willing to pay for this, what happens is a lot of people will use a tuberculin syringe to withdraw vitreous fluid from the globe. Now, technically, this is very dangerous. In most cases, nothing will happen, but this is dangerous because, the vitreous traction that you induce can cause a retinal break or a retinal tear and lead to retinal detachment. So then you are faced with a double problem, that is endophthalmitis along with retinal detachment. So this is, very difficult to manage, and it can, the outcome is moderate at best in these cases. So a vitreous biopsy would be taken with a vitreous cutter itself. So you introduce the cutter.
Hello.
Hello. Am I audible, sir?
Yes, you are audible.
Sorry, I thought somebody couldn't hear her. So
No.
a vitreous cutter is introduced into the center of the core vitreous. It is considered to be a dry tap. So normally when we do a vitrectomy, we are infusing balanced salt solution from one tube and we are cutting with the other. However, to avoid dilution of the sample, we use a vitreous cutter without turning on infusion. We take about 1 ml of fluid and then we turn on infusion. So the globe will naturally collapse because the total volume of the vitreous is just 4 ml. And if you remove 1 ml, that is 25% reduction in volume. So the infusion has to be in place. And the moment the globe starts collapsing, that is the eye, you switch on infusion. And then try and achieve an absolutely complete vitrectomy, including what we call a posterior vitreous detachment. So if we look at the anatomy of the eye, the vitreous is, applied to the retinal surface. And it is attached in some places such as the disc, along the blood vessels, and the ora serrata, and so on and so forth. But it is important to achieve a complete removal. Why? Because the vitreous itself acts as a nidus for infection. And if we leave vitreous on the posterior pole, that is the disc, the fovea, and the macula, what happens is that the toxins from the bacteria have a chance to diffuse into the retina, cause retinal atrophy, and severely compromise your visual outcome. So the point here is to remove vitreous completely. At the slightest doubt of residual infection, it is best to leave silicone oil in the eye. The third thing is that fungal endophthalmitis. What happens is during surgery, once you've cleared all the exudation and the inflammation, you will have a pristine view of the retina. But the next day, there will be no view or a very foggy view of the retina. So this is very characteristic of a fungal infection. And those are the ones that are the hardest to treat. Why? They start off, many weeks after cataract surgery or after, such events like say systemic illness. And then the patient has no correlation between the two. Even the doctors, sometimes they tend to not look at the past history. It grows slowly, but once it grows, it is entrenched in the eye, and removing fungal infections is very difficult. The other problem is intravitreal antifungals like amphotericin B are extremely toxic, which means that they have to be diluted thoroughly before injecting in the eye. And that is what, sometimes compromises outcomes because you cannot deliver the right dose. So in these cases, good intravenous or systemic coverage from antifungals is also equally important. So I thank you all for your time, and I would love to take questions, and thank you so much for having me once again.
Thank you, Dr. Aditya. A wonderful presentation, giving us a overview of how systemic considerations have to be taken into account when you deal with eye infections. So the house is open for questions and comments. I think we have Dr. Pradeep Seth also in the audience. Pradeep, any comments? Pradeep is a very senior ophthalmologist and a good part of our Saturday Club of Baroda.
Hi, good morning, everyone. Am I audible?
Yes,
sir. Good morning.
So actually, there is nothing, that Aditya has left behind.
Thank you, sir.
It's a wonderful and excellent presentation, backed up with a lot of work that he's been doing as a retinal surgeon himself. So congratulations, and I'm sure this gives good insight to the non-ophthalmologists present in the group.
Thank you very much.
Yeah.
Any other questions?
I have, Dr. Aditya, I think
Yes,
preventing infection should be great priority in all ophthalmic surgery, because giving intravenous antibiotics also, they don't reach inside the globe.
Absolutely.
So that's one thing. Another thing, how you give intra-orbital injection, you puncture through the orbit?
Yes, sir. So just to follow up, I'll just address both of your things. And intravenous, definitely. And generally, with inflammation, the blood-retinal barrier is a little compromised. So some antibiotics do reach. And especially what we have seen is that oral linezolid has excellent intravitreal penetration. So for gram-positive infections, 600 milligrams linezolid twice a day for at least 5 to 7 days is what we generally give. Now, but yes, that is the whole problem, that intravenous or systemic antibiotics often don't reach the eye because it is a privileged organ. Now, as far as the intravitreal dose is concerned, so we go in through the sclera and we go in about 3.5 to 4 millimeters from the corneoscleral junction, what we call the limbus. So if the patient has his natural crystalline lens, what we call a phakic patient, that is, he or she has not been operated for cataract, the preferred distance would be between 3.5 and 4 millimeters from the limbus in the inferotemporal quadrant, that is the inferolateral or inferotemporal quadrant. Reason being, the pars plana, the ciliary body has two parts, the pars plicat and the pars plana. The pars plana is widest in the inferotemporal quadrant, and it is an avascular structure. So if you go in through there will be minimum to no chances of bleeding, and there will be no damage to the retina. If you go 4 millimeters or beyond from the corneoscleral junction, there is a chance that you might go through the retina and induce a break. So intravitreal antibiotics, just to for the sake of completion, the standard dose intravitreally for vancomycin would be 1 milligram diluted in 1 milligram per 0.1 ml. So 0.1 ml is the maximum volume that we would want to inject in 1 case. Now what happens is that a lot of times we combine 2 or 3 antibiotics along with intravitreal steroids. So 0.1 ml each. It would be vancomycin 0.1 ml, ceftazidime would be 2.25 milligrams per 0.1 ml. And we would have the third, which is dexamethasone, which is 400 microgram per 0.1 ml. So then 0.3 ml is a significant increase in volume, for the eye. For us, it is a very minute, but for the eye, it can actually cause raised intraocular pressure and cilioretinal artery occlusion. So then we have to monitor the pressure. We have to see the optic nerve on table. And if that is occluded, if the optic disc appears white, we actually have to do an anterior chamber paracentesis to release the pressure. So, it's a very delicate balance.
Yeah.
A lot of micro precision is required. No? How do you ensure all this? I mean, a lot of technology is used for measuring millimeters and 3.5, you said.
Half a millimeter here and there can seal the fate of the patient. Yes, sir. Sir, you're muted.
You're muted.
Hemant, you have to unmute.
Hello. Why
Yes,
not
sir.
steroid be banned for all red eye? Because what I have seen in last 40 years is, apart from the ophthalmic surgery mistakes or sterilization, which leads to endophthalmitis and diabetes, the most other common group is the red eye, where steroid included antibiotic drops are very common, either by doctors or by self-medication.
Self-medication, sir.
So what is your opinion? Why steroids should not be taken away from all the eye drops, most of the eye drops?
Yes, sir, the problem is with steroids, it is a double-edged sword. In endophthalmitis, on one hand, it can induce endophthalmitis, but after vitrectomy, it considerably helps reduce inflammation as well. Now, the problem in India is that because it is in that DPCI, that drug controller program, a plain steroid drop would make maybe 10 or 20 rupees, and that is not productive for most ophthalmic companies. So what they do is they combine it with antibiotics, and they are actually promoting antibiotic misuse, because then prednisolone is available as a standalone thing, but sometimes you need dexamethasone because of its potency. So there is only one pharmaceutical company which manufactures dexamethasone. So absolutely right, sir. Steroids, they can work both ways, and what is extremely important is that controlled use. Now what happens is that with allergic conjunctivitis or even bacterial conjunctivitis, steroids do play a role in bringing down inflammation, but it has to be a measured dose, like say 4 days or 5 days, and under physician supervision. What happens is once the patient starts steroids, he or she feels very well, and they just continue it. Maja aave drops nakhwani. So this is what they say. And then not only sir infections, it causes rise in intraocular pressure as well. So a lot of cases of steroid-induced glaucoma, especially
So
in pediatric patients.
my complaint, Aditya, is why not Ophthalmic Society of India and academics like you write to the CDSTO, correct, where people are listening, and the media and things, and most important, when conjunctiva is so blood
Rich in blood.
blood rich, we should give oral anti-inflammatory and stop completely the local anti-inflammatory, because immediate action is needed by this Indian mindset and ophthalmologists who are in practice. They want to cater to this mob mentality. Tarat lal eye, that is the main cause of infection in diabetic persons.
Yes, sir. So that's what. So, steroid prescription should be solely on ophthalmologist, on the prescription, and that too a discerning ophthalmologist prescription. So that is
I
true.
know that, but what has Ophthalmic Society done to write to CDSCO that it should be a Schedule X drug, punishable by offense if you write a ophthalmic drops with steroids? That is all I want to say.
No, sir, but post-operatively we do need it. Cataract surgery. After cataract surgery or any surgery, steroids are so that's what, sir. It is a very dicey thing. If we write a ban, it would actually compromise outcome. So nowadays we have these steroid implants for retinal disease, and it is surprising that conditions like sympathetic ophthalmitis, where even IVMP does not work to resolve the drug fully, but there is this sustained release implant called Ozurdex. It is manufactured by Allergan, and it is a dexamethasone sustained release implant that has a superior effect to even IVMP in sympathetic ophthalmitis or uveitis management. So that's also more than a blanket ban. What is needed is very controlled regulation. What we have in the US or in the West, where antibiotics cannot be prescribed randomly. The other problem with what you said is not just steroids, the misuse of antibiotics. So it is rampant. Viral conjunctivitis, you have to give it with an antibiotic, because that is the only way you can prescribe a steroid, except prednisolone.
So this is an issue of rational therapy actually. Basically, we all as medical professionals should keep promoting use of judicious use of medications which are available. As far as their availability is concerned, sometimes it is actually beyond our control also, because we as society like say IAP, we have been writing to drug control so often. So after many years of struggle now, the cough cold mixtures, which were totally irrational, in a notification couple of months back, they will not be used below 4 years of age, which was there, in USA for last 2 decades, that they label the cough mixers bottles as not to be used below 4 years of age. It took such a long time for us to, get to this stage, and still the bottles are not carrying these labels. We have to repeatedly tell the parent that these are not the right medications to use. So it's a movement. We have to fight with the authorities as society to promote the rational use of whatever medications that we are discussing. So Hemant, your point is well taken. And of course, Aditya, are you part of some society also, ophthalmic society?
Yes, sir. So the Baroda Ophthalmic and the All India Society as well. So, and they are proactive in the sense that recently we had a problem with silicone oil that we use for retinal disease. So particular company silicone oil, it was infected. And, some of these non-tubercular mycobacteria cases actually came out through those silicone oil things. So they were very proactive in, recalling that entire batch and everything. So, what Dr. Sant sir just said, Hemant sir said, we can actually take it up, and that judicious use. But what happens in the US is perfect, where you cannot randomly prescribe antibiotics or steroids without a prescription. And then, that is controlled, where it is supervised. Then, how many days and how many weeks. So, but such I don't know, quality control is perhaps missing in our thing. It is there in theory, but not in practice.
Gradually
Write a letter to CDSCO, please.
Okay, sir. Okay, sure.
Any other questions or comment? Great. So thank you, Aditya, once again.
Thank you, sir. Thank you very much for having me.
We are all very, me and my older, senior peoples are very happy to see the legacy of Sudhalkar family.
Thank you.
Yeah. So well. Yeah, we are really very happy with your.
No, thank you, sir. No, and like I said, please do take me up on the on the other topic that we discussed, the non-academic topic, definitely. Which is actually more relevant than everything else, perhaps.
It will be very interesting. Actually.
Not just astrology, sir, the whole perspective of life itself.
Okay.
And that we,
life,
that we as decaying organisms, how much importance we give to our own lives, and why we should not give so much. That is the whole point.
It will be very interesting. We'll definitely.
Okay, sir. Whenever everybody is okay with it. Thank you, sir. Thank you so much.
Thank you all. So we end the session here.